me repeat that in case you didn't hear because we were muted. Budget some of your energy and the resources towards keeping the ship afloat, dealing with the current care, the proposed cuts, etc., while devoting energies as well to those new opportunities that are out there. If you don't, somebody else is, and they will be the one who succeeds. So clearly, people that are at the forefront of the home health industry and who have been there for up to 30 years feel that this is a unique time that we're heading towards, that home health will be changing. They may not even call it home health, that you're going to have to figure a way to demonstrate your value, and you're going to have to find new ways of moving patients forward in the future. Now, we're going to describe today some of the things that I've been running into in the community, and let me review some of those. It's very rare that I don't get asked by any provider that I work with how to get involved in the ACOs. How can I get on the list of ACOs? How can I get involved in the ACOs? What if the hospital I work with has a hospital-based agency? How will I get patients? So let's review this point in time in the home health industry. Some providers are going to close. Estimates over the next 3 to 5 years will be a loss of 30 to 50% of the current providers. It's important to understand that those providers who are going to be lost to the future are those providers who are unable to move their care forward. As we speak, we have people continuing to do what they've always done at all points in their care delivery and not trying to modify for the accountable care organization model that we're going to see in the future. Now, we're going to have changes that are going to be required for success in the future. It's not just reproducing the care programs of the past. Those changes that are going to be required occur in the future than in the past. So what are you doing on today or tomorrow? What are you doing on Tuesday, October 23rd, to start to work on decreasing the amount of visits you provide per episode without compromising your care, decreasing them on a nursing level and decreasing them on a rehab level, decreased payments for rehab. So what are you doing to make sure that your rehab is focused on October 23rd in a way that has not been focused to date? How are we making sure that our rehab connects to the clinical acuity of the patient, what's happening with the patient, and how we're moving them forward? There will be increased scrutiny on your cases. Documentation that must be timely and documentation that's going to be read for coverage by people in the accountable care organization. So what are you going to do on October 23rd to start to make sure that your documentation starts to be written with those two goals in mind? Next, integration into the team. Are we making sure that the physician and all other team members know what's going on at all times with our care programs, or are we struggling to get the nurses and the therapists to call the doctor after their evals and validate their care plan? Because if you can't get communication from your individual clinical members on the team, you're not going to be able to participate in the ACO bundling. So look at these 4 or 5 areas that you can start tomorrow, Tuesday morning. And are you focusing on clinical content, or are you still making sure that your programs are defined by length of stay-based care? When I go into 10 agencies and wonder what they're doing here, 9 of them are still doing the same old component, length of stay-based care. So you've got areas to start today to work on getting ready for the ACO of the future. It's not going to just happen, and even if you get onto an ACO or a bundling roster, if you're not prepared to perform in these areas, you won't be on that roster long. Now, the decreased utilization, how can we address that? We're going to talk about the effect that will happen on nursing care plans and nursing delivery. When I review agencies' care plans that I think are exactly the opposite of what the ACO looks like, there are 2 things that jump out at me. Number 1, agencies that write 9-week nursing orders are not preparing their nursing staff for the requirements of the ACO and the bundling model for 30-day hospital readmission changes. Patients who write 1 times 9 nursing orders for anything other than chronic care patients are certainly not setting themselves up for ACO post-acute bundling patients. And then how is that care delivered? Is that care delivered in an acute and skilled manner, which says that every time the nurse enters the home, there will be changes that move the patient forward into a healthier corner, that there will be home programs with full involvement, full compliance, and full caregiver delivery, because those are the things they're going to be looking for in the ACO. So again, those you're in areas, those can start tomorrow morning, Tuesday, October 23rd, on polishing these elements. Then effect on rehab care plans and delivery. Rehab care plans, are they connected to referral orders or are they connected to OASIS data? These are the things that you're going to be required to demonstrate if we expect to work under the bundling model. Because rehab care plans, they're not based directly on clinical deficits. They're established by ACO or a bundling model. In order to perform those, we need OASIS accuracy. So what are we doing with our OASIS accuracy? Are we blindly scrubbing it, or are we paying attention to the programming questions that make common clinical sense to us and to our clinicians, so that we can make sure that our plan of care is compliant with that OASIS data? When I look at 100 charts, I see less than 10 who I feel that are OASIS accurate to the level that you could create a plan of care out of the data. Utilization review for all clinical programs. Now this is one that I find interesting. Everybody thinks that they can manage their care by letting the nurses who have done it for 10 years manage themselves, and by letting the therapists who have done it for 10 years manage themselves. So it's important to understand that's not you are. And if you're going to be in the ACOs and the bundling, you're going to have to start to perform utilization review for all of your clinical programs. Every start of care, every clinical evaluation should be started. Put these programs together now and start to derive the changes that are possible as a result by moving it forward. Fresh staffing whenever possible. Traditionally, assigned nurses or therapists to the same patients tends to produce less skilled changes and less objective changes than fresh staffing. So when are you going to start that in your agency? When are you going to tell Mrs. Smith that her favorite nurse, Barb, is not available and send her a new nurse who will treat her as a new patient? Those changes are required. And you can always look for somebody else to invite you to be on an ACO or help lead you onto a bundling roster, but you won't stay there unless you've been addressing these up until now. Understand the depth of required changes. It is almost exactly the opposite of where we have been over the past decade under PPS. So it's important to understand that you need to continue to evolve that if you want to perform in the future. Decreased utilization, how do we continue to address decreased utilization? It's important to understand that patient responses modify our care programs. So how are you addressing each clinical program and each clinician on a daily basis to assure that these patient response modifications are occurring? Replace case conferences. If you're still getting everybody together and meeting in the program, you're probably not providing a care management approach that ACOs are going to recognize or desire. You're going to want to start to replace those with weekly clinical rounds on a per clinician basis today. So in the agencies that we work with, it's as simple as obtaining a roster list of all the clinical staff members and starting to move those clinical rounds forward. It's a pain. It's like tearing off a Band-Aid. It hurts initially, and it needs to be started at some point. So if you're waiting for an ACO to exist in order to make these changes, you're probably going to be behind the curve and in jeopardy of being one of the percentage of agencies or providers that may be lost in the transition. What does Medicare want? This is a practice that you should start with every program that you see today and in the future. How do we look at the OASIS? How do we determine what Medicare thinks we should do with this patient? Not what the patient wants, not what the caregiver wants, not what the doctor wants, but in fact what Medicare would define as the desired clinical program. Somehow we have to consciously deliberate this topic so that we can perform in the future. How do we deliver then what Medicare wants? Are we good at it, or are we just figuring out what Medicare wants so that we can do our traditional care approach that may or may not work for us under the ACO model? It's important to understand that delivering what Medicare wants is an entirely different trip than the one that we've been on. It's a culture change. It's not about making the doctor, the patient, or the caregiver happy. Certainly it's about those things, but in the past, those things might have been only all that was required for a successful home care program. And in the future, you're going to need interior and intrinsic clinical content if you want to move it forward. So these things aren't easy. These are hard for progressive agencies with outstanding clinical responses to change. If you have any areas under those headings in which you lag behind performance-wise, you're going to need to start that now. And that's what I'm encouraging. I was thinking about that when I worked with a couple of agencies last week who are very intent on participating in ACOs, but actually are the exact opposite end of the spectrum of what the ACOs might be looking for. But that doesn't mean you can't get ready and you can't produce care that would qualify for an ACO level. So what are the chronological steps? First, analyze your current care programs. Pull out 10 cases tomorrow. Ask themselves, does the OASIS make sense in the areas of programming? Do we have programs that relate to what the OASIS tells us in the areas of programming? Will we be able to continue to move those programs forward under our traditional care approaches? Do our current care programs work for that? There should be 5 to 10 cases analyzed. They should not be described by the frontline clinicians who are going to tell you stories that take you out of the area that we're trying to focus on. Now, by analyzing program after program objectively, we're able to notice some care tendencies and directions that may or may not service the clinical components. We need to identify those program tendencies and address them. Are they positive? Are they negative to the overall outcome of the patient? Are they consistent? Are they skilled, or are they basic? Are they assigned to each and every client, regardless of whether they have care needs that in fact are addressed by the OASIS data? And how do they work? Would you continue to pay for them privately if you were paying for them? Next, what's the scenario regarding the objective elements of our documentation? Is it skilled? Does it demonstrate skill? Is it in a timely manner? Because we're going to expect to read the notes the day of care. Now, maybe in many instances the day after care was addressed. But you're going to need to write the note the day that the care was provided. So are your clinicians doing this? You know the answer to this. Of course they're not. When are they going to start writing these notes? When you get an ACO patient and you tell them? Because that's going to be too late. They're not going to be practiced at it. So again, documentation timelessness and timeliness, so that we can make sure that our clinicians are able to provide the notes that the clinicians in SNFs and hospitals provide. What wasn't addressed? What didn't we take a look at in the care program? And should we have taken a look at that? What was addressed? Did we pay attention to the important things, or did we pay attention to the referral items, or did we pay attention to what our clinicians pay attention to on this and every case similar to this? How did we address that, and how long did we address that? Did it work? Did it make sense? Would somebody who wasn't being paid to address this agree with how long we addressed it? Many, many crucial issues with regards to the ACO and bundling. If you haven't been in a bundling model, you may not believe these things to date. But in bundling models, we're making sure that we don't want to provide one extra nursing visit. We don't want to provide one extra or unnecessary therapy visit. Those are costs that we can't validate under the ACO model. How do we change things in the home? Or do we change things in the home? If we don't, what is our value to the bundling model or the bundling role? Because that's going to be a nakedly transparent topic you to support us as a cost center in the ACO model and in anybody's individual ACO program. So again, these things take time. You should start yesterday, but you have to start. Now, Next, analyze rehab production and delivery, because rehab is going to be such an important focus of the ACO model that it's going to be important that you are able to produce defendable and reliable rehab programs. That means you're going to have to assess how you rehab programs. Is it just what the therapist wants to do? So do we have traditional contract problems? That we have a lack of reliability and a lack of performance because we're unable to manage them because they're contractors? Or do we have good contractors? Or do we have those exact same problems under the employee level? Because the misnomer is that the employees are easier to manage and more productive than the contractors, and sometimes our experience tells us that's exactly the opposite. Do we have care intensities that match the OASIS data? Or are our rehab clinicians working on an island by themselves, disconnected from the rest of the team and doing their own thing because we're afraid to talk to them, or they're not available for us? Because unless you're reinforcing that, you probably don't. For involvement in the re-performance of the home program to advance it on a per-visit basis, again, unless you're addressing that, you probably don't. What is the timeliness of our documentation, especially if they're contract clinicians? Because, again, no one will wait longer to read the documentation from your contract clinicians just because they're contract. How are our rehab providers doing logging vitals? Are we still struggling with them about that? How about communication between the agency, the patient, and the clinician? And how about compliance in their rehab programs? Because sometimes we lag behind in these areas based on this approach. So after we've addressed both nursing, our charts, and our rehab, we want to seek to create new program efficiencies. What areas can we develop that we've seen care lapses during our analysis and assure that we're going to provide more timely and specific care delivery so that we could possibly produce changes with less cash outlays for each particular episode, less spending, better wellness. Next, change the status quo of your care. And I want to make sure everybody listening understands this. If you're not doing something on Tuesday, October 23rd through Friday, October 27th, I think it is, you're falling behind. This is not something we can start next week. It's important to understand that other people have started. Other people are already on board. So when we say, well, we're going to wait and see what ACOs look like, well, you should be prepared to be one of the third that don't survive. When you're thinking that we're a good agency, we have no concerns, I have not run into that agency yet. Even great agencies have concerns. So what are you doing to change the status quo of your care? You have to change how you do it traditionally. So those are elements that I think are important. Let's make sure winners and losers. Some patients that we've seen in the past may not be patient programs that work for home care in the future. Some clinicians you have may not be home care clinicians that will work for the home care of the future. Some clinicians you have will be winners in the home care model of the future. Start to identify who's going to make it and who's not going to make it. People who cater after referral sources solely to any other clinical approach. People who are held hostage by frontline clinical staff that have been unmanaged in the past and are unmanageable now. Those are going to be staff members who aren't doing what you need them to do. You need to start putting obstacles in their way so they understand how unwilling you are to let them continue with the care lapses and the future changes. If somebody's doing good, they need to be called in at the end of the day and told how good they're doing. Presenting a problem, not working with you on creating a reliable start of care OASIS, not connecting with you to find out how you can deliver more efficient care in the future, connecting with the patient in lieu of the agency or provider, and basically hostaging the agency to provide the caregiver or patient and how to start. And I think it's painful sometimes, but it does pay off. We're going to start to write a little more assertively about ACOs and bundling under the newsletter. If you are not a a subscriber to the HHSM newsletter, please do so. You can subscribe on the front page of www.homehealthstrategicmanagement.com. If you're going to start moving ahead in your analysis and you have questions, you can certainly contact me at the 877-449-HHSM number. But I want you to know it's October 22nd today, and I think 6 or 7 agencies that we've never worked with before have worked with us in the month of October so far, in fact, in preparing for 8 bundling. So if you're not starting now, you're falling behind. And don't forget, it's not just falling behind, it's possibly falling behind to become one of the 25 to 30% of the providers who are not going to survive this change, because Medicare and National Association of Home Care has gone out of their way to say that they feel that possibly is the extent of provider loss that we could be confronting here. So don't kid yourself. Imagine yourself in a line of cars, and each car represents a home health agency, and they're pulling one of every 3 cars out of the line that won't continue on the road of home health. That should frighten you, and you should use that concern to mobilize yourself forward into the healthcare delivery model of the future. So we're going to end a few minutes early today, but we still do have times for comments and questions, and I think you can type them in, and possibly Andrew can read them to me as we move forward. Again, please feel free to contact us at 1-877-449-HHSM or www.homehealthstrategicmanagement. And thank you for taking time for this 3-part webinar series to try to help you understand where we're going, and I hope it gave you opportunities and ideas of where to begin to start on your future today.